Welcome to our MyIBD Learning Virtual Program, Diet as Therapy in IBD. My name is Dr. Shannon Caravello. I'm an assistant professor at the City University of New York. I'm also a Crohn's patient who was diagnosed in 2019. I will be your moderator for this evening. Tonight, we plan to explore the latest updates on diet therapies that have been studied in IBD to induce and maintain remission. Our hope is that you will learn how to include dietary therapies into your day-to-day so that you can live your best quality of life. Please note that the content of this program may cover some advanced concepts or go into greater detail. Be sure to stay until the end of the program for additional resources from the Foundation on Diet and Nutrition. In order to make the program more interactive and find out how much you've learned tonight, we'll be asking 2 questions via a poll on your screen now. So let's start with the first question. Exclusive enteral nutrition, which is 100% of nutrition from a liquid supplement, is most effective in inducing or maintaining remission. The question directly below that is which diet has been the least well-studied for IBD? Choices are Mediterranean diet, Crohn's disease exclusion diet, gluten-free diet, low-FODMAP, or specific carbohydrate diet. So I'll give everyone a few seconds to make your selection now. At the end of the presentation, we'll ask these questions again and see how much the group has learned. Okay, great. Thank you for your participation. It looks like most people selected inducing remission for question number 1. And for number 2, it looks like we have the specific carbohydrate diet. All right, on behalf of the Crohn's and Colitis Foundation, thank you all for joining tonight's programming. The information shared is meant to be for educational purposes only and should not replace any advice or guidance from your own healthcare professional. This program will be recorded and posted on the MyIBD Learning website, and everyone who registered for the program will receive a link with the recording next week. We want this to be as interactive and engaging for you as we can. Encourage you to submit your questions. Please be sure to do so through the Q&A box, which can be found at the lower part of your screen. Following our expert discussions, I will moderate a Q&A session with all of our panelists, and we'll address as many questions as we can at that time. Tonight, we have the opportunity to hear from registered dietitian David Gardenier. David Gardenier is a registered dietitian at the Cleveland Clinic, specializing in inflammatory bowel disease. His interest in nutrition and IBD started after he was diagnosed with Crohn's disease in 2016. Since then, David has prioritized educating others on the importance of nutrition in IBD and now serves in the Crohn's and Colitis Foundation National Scientific Advisory Committee, helping with patient education. We understand the importance of your questions and want to make sure that we answer as many of your questions as possible. Tonight, we have the honor of having registered dietitian Danielle Gaffin monitoring the Q&A box. Danielle Gaffin is a registered dietitian nutritionist with a BA in kinesiology from Rice University and a master's in nutritional sciences from San Diego State University. After helping her husband navigate the nutrition challenges of his Crohn's disease, Danielle founded Eat Well Crohn's Colitis, a virtual practice dedicated to supporting people with IBD. As an IBD dietitian, she helps patients gain confidence around food and helps manage their conditions with personalized, evidence-based nutrition strategies. If you have a question for Danielle, please type it into the Q&A box. She will do her very best to answer as many questions as she can, keeping in mind she may not be able to address every question. Following David's presentation, Danielle will join him for a live Q&A session. Listed here are our speakers' financial disclosures. Now, let's get started with tonight's presentation. At this time, I'd like to welcome our presenter, David Gardenier.
Thank you, Shannon. Today, I'm going to be talking on the subject titled Diet Therapy for IBD. Going to start out with some objectives for this evening. We're going to first define remission or define that target that we're aiming for. We're going to highlight some of the diets that have been well studied in IBD and really discuss a little bit of the evidence base we have currently. We're going to discuss who specifically can benefit from these dietary therapies. And then we're going to kind of put all of that together and talk about some of the different dietary options that have been shown to help induce and maintain remission. So let's start out with this concept of what is remission, or what is this target that we are aiming for? There's a few different definitions of remission. The one that most people are familiar with is clinical or symptomatic remission. This is really just the absence of symptoms such as diarrhea, abdominal pain, and bloating. And this is really what patients really strive for, right? Just feeling better in general and feeling normal. There's also this concept of biochemical remission, and this is the normalization of our inflammatory testing, such as fecal calprotectin or C-reactive protein. So if we get those labs drawn and they're normal, we consider somebody in biochemical remission. There's also the concept of endoscopic remission, and this is when we actually do a colonoscopy or EGD. We look at the bowel wall and we see that it is normal. We see there's no ulcerations. Everything visually looks good. We would consider somebody in endoscopic remission. Finally, there is histological remission, and this is when a pathologist views some of the samples taken from a colonoscopy or an upper scope or EGD underneath the microscope, and then can actually visually see on a cellular level that the bowel appears healthy and normal. And so a few different definitions to think about when we're talking about clinical remission, or we're talking about our goal of remission with these diets. And this is very, very similar to what we actually use for our medications. This is the STRIDE-2 guidelines, and it is on treatment targets for people with inflammatory bowel disease. And you can see it's pretty similar to what I just discussed. We have active IBD on the far left over there. We introduce some sort of therapy, normally medication. And in the short term, our target is normally symptomatic or clinical remission. An intermediate target is our biochemical remission, normalization of CRP, decrease in fecal calprotectin, and then our longer term targets tend to be endoscopic healing or endoscopic remission. And then you could see in the box on the far right there for ulcerative colitis, histological healing or histological remission. And so this is something that we need to consider. Our medications are designed to get us into remission. And if we're thinking about diet from the same perspective, a diet to induce remission, we also have to think about what specific type of remission are we targeting, and really how far can these diets actually get us down this track. I also think it's important that we understand some of the evidence and kind of discuss some of the research base that we're going to be talking through tonight. So this is a really nice study done back in 2023, and it's pretty much aligned with the title of our talk. It's a review of solid food diets for induction and remission of inflammatory bowel disease. And you can see there for clinical remission in Crohn's disease, the authors found that the specific carbohydrate diet was about equal to the Mediterranean diet, with medium quality evidence, or about 2 of those little dots filled there. They also found that partial enteral nutrition was about equal to exclusive enteral nutrition, again, for Crohn's disease and clinical remission. Now, when we think about risk of clinical relapse or maintenance of remission in Crohn's disease, the authors found that a diet low or high in red meats were about equal overall. So there was no difference, or a reduction in red meats did not reduce the risk of relapse for people with Crohn's. Similar for refined carbohydrates, they found that a reduction of refined carbohydrates did not reduce the risk of relapsing Crohn's disease. However, they did find that partial enteral nutrition did reduce risk compared to a normal or controlled diet. Now, you'll see it was all about Crohn's disease in this study. There was no specific diet type found to be helpful for induction or maintenance or remission for ulcerative colitis. And this is just due to the small sample size or the lack of studies that we currently have specifically on ulcerative colitis at this time. And I also want to highlight some of the individual diets and discuss the evidence there. Kind of talking through this diagram, on the left, we can see this triangle, and at the very top is the highest level of evidence, systematic review of trials. Just below it is randomized trials, and those are two types of evidence that we consider stronger overall. And then looking at these colors here, we can see that green is we tested the diet against a control or something that we know works. That's a pretty strong level of evidence. And on the far right over there, the yellow color indicates there was no control or comparator, tends to be weaker. So the diets with more evidence or stronger evidence tend to be on the top left of this little graphic here. And we're really going to be focusing today on exclusive enteral nutrition, the low-FODMAP diet, the Crohn's disease exclusion diet, the Mediterranean diet, and the specific carbohydrate diet, because we have stronger evidence supporting these diets overall. So we're going to start with exclusive enteral nutrition. Overall, the definition here is a diet that 100% of the nutrition comes from a nutritionally complete supplement. And I've kind of broken down based on the research that we have, who specifically can benefit from this diet, or where has this diet been studied as far as our patient population. So you can see I split it into pediatrics and adults, Crohn's and ulcerative colitis, the severity of IBD, and then at the very bottom there, kind of circling back, the type of remission that the diet has been shown to be helpful for. So for exclusive enteral nutrition, this has been a mainstay in pediatric Crohn's disease for a long time. It is a first-line therapy due to its ability to prevent steroid use, which can affect growth in pediatrics and children. It's also been studied in adults, but it's been found to be slightly less effective. So I put a slightly less strong green color there to indicate that. We really primarily have studies in Crohn's disease at this time. There's one very small study in ulcerative colitis, but we really need more information there. For the severity, we use this primarily in moderate to severe Crohn's disease. This is a very restrictive diet, and there tends to be better options for patients with mild disease. So that's why I've listed it as moderate to severe. And then when we look at the type of remission, this can help induce symptomatic, biochemical, and endoscopic remission for people. And this page here, this slide here, shows a little breakdown of exclusive enteral nutrition. So like I mentioned, 100% of calories are consumed via this oral supplement. No other food is allowed on this diet. It is very restrictive overall. And you can either do this diet by drinking the supplements or via a feeding tube, if that is already placed. It does not need to be an elemental formula or a formula where the proteins have been broken down. A regular whole intact protein formula works perfectly fine for exclusive enteral nutrition. And so why does this actually help people get into or help induce remission for people? There's really three main reasons overall. We tend to see an anti-inflammatory effect due to the exclusion of really all the other food antigens or food proteins in the diet. Again, we're not really sure what triggers inflammation for people with inflammatory bowel disease, but by excluding all those other environmental factors coming from food, there potentially could be an anti-inflammatory effect there. There's also a correction of nutritional deficiencies. So we know that nutrients like zinc, selenium, vitamin D, all play a key role in the immune system. And if somebody's deficient in those, that can potentially be hindering their ability to get from a flare-up to remission. This diet is very good at correcting those because the supplements are nutritionally complete. This diet also allows for people to meet their protein and calorie goals, and that is really important for wound healing. If somebody has ulcerations or damage in their gut, getting enough protein can really help those wounds heal up and help somebody reach remission as well. Finally, there's a correction of dysbiosis. So we know that people with inflammatory bowel disease tend to have a shift in their gut microbiome, or the types of bacteria in their gut, to be more pro-inflammatory or more pathogenic. And on this diet, we see a correction of that to a more balanced microbiome or a more anti-inflammatory composition of gut bacteria. So it kind of begs the question of how long should somebody be on exclusive enteral nutrition if their goal is induction of remission? Based on the research that we have now, we recommend about 6 to 8 weeks total for induction of remission. You can see there's a few other indications that we use exclusive enteral nutrition for as a bridge to medical therapy, prior to a surgery, or to manage something like an abscess or a fistula. And the duration changes a little bit if we are, or if the indication changes to one of those other factors there. And so what about maintaining remission? We talked a little bit about induction of remission overall. We don't really recommend exclusive enteral nutrition as a great option to maintain remission due to the restrictive nature. Normally, people go on this diet again for about 6 to 8 weeks, and then they transition back to a whole foods diet. We have, however, found that partial enteral nutrition, which is getting about 30 to 50% of somebody's nutrition from these supplements, has been shown to be effective at maintaining remission in Crohn's. And this tends to be a better option overall because it allows for a little bit more variety and variation in the diet. Speaking of partial enteral nutrition, let's talk a little bit about the Crohn's disease exclusion diet. This is a 3-phase diet that was designed to mimic exclusive enteral nutrition while providing a little bit more tolerability and a little bit better variety overall. It's been studied in both pediatrics and adults, primarily in Crohn's disease, although there was one very, very small study in pouchitis. And most of the studies of the Crohn's disease exclusion diet have been in patients who are mild to moderate Crohn's disease. We have found that this is helpful for inducing symptomatic remission, biochemical remission, but there's only been one study on endoscopic remission at this time, and while it was promising, I left that at a light green to reflect that. And so what is this diet, or what does it actually look like? This is a 3-phase diet that is a combination of partial enteral nutrition plus a list of mandatory and allowed foods. So on that first phase, weeks 1 through 6, half of somebody's nutrition will come from a nutritional supplement, and the other half will come from a mandatory food list, including chicken, eggs, potatoes, bananas, and apple, as well as an allowed food list, things that they could do on top of those mandatory foods during the 6 weeks. The second phase, the amount of nutrition from supplements goes down to about 25%, and the allowed food list expands, giving a little bit more variety for those 6 weeks. And then in the third phase, or the final maintenance phase, the amount of partial enteral nutrition stays at about 25%, and people are encouraged to follow the phase 2 diet on weekdays, so Monday through Friday, and then having a little more flexibility or liberalizing the diet on weekends is what is recommended. There's a few permanent restrictions, but overall, it's a lot more freedom on this maintenance phase compared to the beginning of the diet. And same thing, why does this diet work for people with Crohn's disease? A few different reasons. One, similar to exclusive enteral nutrition, we see a nice shift in the gut bacteria from being more pathogenic or harmful to a more balanced composition that's more anti-inflammatory. We also see that there's a reduction in, or an improvement in, intestinal permeability. And so if we look at the graphic here, on the left, people with Crohn's disease in a flare-up or who are on a westernized diet, if we look at the mucus layer, that green line, you can see that it's very thin, and the bacteria get very close to the bowel wall. And this is something that can certainly stimulate the immune system in a negative way, or potentially lead to inflammation for people with Crohn's. And on the Crohn's disease exclusion diet, that mucus layer becomes a lot thicker. There's a much larger barrier between the bacteria in our gut and the wall of our gut, and that potentially can have an anti-inflammatory effect. I'll also mention there's a change in tryptophan metabolism on this diet, but it is a lot, so we're not going to get in the weeds there, but I did want to mention it because it is something that we do see. And let's talk a little bit about some of the benefits of this diet, and then talk a little bit about that maintenance phase as well. So some of the big benefits are we get to incorporate whole foods, while on EEN, we're only using a supplement. So incorporating whole foods allows for better adherence, the ability to do the diet for a longer period of time, and more autonomy or choice, being able to put meals together, actually choose what you're eating versus only doing a supplement. We have found this diet to be similarly effective to exclusive enteral nutrition at inducing remission in children with mild to moderate Crohn's disease. It also has been found to improve growth rates for children and can be used as a salvage therapy if somebody is losing response to their biologic, specifically patients who are pediatrics or young adults with Crohn's disease. There's not a ton of research on this maintenance phase or the diet, post 12 weeks, but two small studies have been promising. The first one found that patients who were on this diet who were in remission on week 8 were able to maintain that clinical remission at week 24. And then another study found that over the course of a year, this Crohn's disease exclusion diet allowed for significant improvement in C-reactive protein and daily stool count compared to at the very start of the diet. We're going to switch gears a little bit, and I've kind of lumped the Mediterranean diet and specific carbohydrate together, so we'll talk about them as a pair. So by definition, these are both plant-based eating patterns that really prioritize whole foods and limit processed foods and added sugars. Studies both in pediatrics and adults. And this is the first of the diets that we're going to talk about that has some good evidence in ulcerative colitis, also good evidence in Crohn's, and there has been some research on the Mediterranean diet in patients with a J pouch, so I've also put this on the slide here. We tend to use this, or it has been studied in patients who have more mild to moderate inflammatory bowel disease, and we see that this diet is very helpful for clinical remission or improvement of symptoms. There is some improvement in our biochemical markers like fecal calprotectin, but we really don't have a lot of data at this time on endoscopic improvement with the Mediterranean diet or specific carbohydrate diet. So this is an overview of the Mediterranean diet. At its core, it is a diet that is built around a lot of vegetables, fruits, beans, whole grains, a lot of those plant-based foods. Mostly plant proteins are encouraged, like beans, legumes, nuts, but there is a few animal proteins like fish, lean chicken, lean turkey, eggs, low-fat dairy also allowed. Olive oil is used as the primary fat source, and the diet limits a lot of the pro-inflammatory foods like red and processed meats, sweets, and sugar-sweetened beverages. And that is really why we tend to see, or why we think we see, some of the benefit of this diet is it limits a lot of those foods that tend to be more pro-inflammatory overall. If we compare the Mediterranean diet and the specific carbohydrate diet, they are very similar, but there are some differences. The specific carbohydrate diet tends to be a little bit more focused on our animal proteins like unprocessed meats, poultry, fish, eggs, and there is certainly a lot less legumes or beans. And the specific carbohydrate diet avoids grains and a lot of the starches and sweeteners. On the flip side, the Mediterranean diet encourages a lot of whole grains, legumes, and there's a lower intake of your animal proteins, especially your red and processed meats. And so when we compared these diets head to head, we actually found they were about equal for induction of remission in Crohn's disease. This was a nice study that looked at both these diets and found that at about 43 to 46% of patients, you can see they reached symptomatic remission at week 6 following either of these diets. When we look at the fecal calprotectin response, you can see that 34.8% of patients on a specific carbohydrate diet had a response, 30.8% on the Mediterranean diet had a response. So it was also helpful for one of those biochemical markers of remission. When we look at CRP, a lot lower numbers there, but it is worth noting that patients who were on this diet had very mild to moderate Crohn's disease, and so the CRP was not super high to begin with, so it's difficult to actually see a huge drop or a huge response there. I wanted to highlight some of the other roles of a Mediterranean diet and specifically talk a little bit about maintenance of remission with this diet. This diet can be helpful for IBD prevention for either the general population or first-degree relatives of people with inflammatory bowel disease. When we look at the impact on patients with IBD, like I mentioned before, we do see an improvement in disease activity or symptomatic remission. We see an improvement in inflammatory markers, biochemical remission there. And then we also see that for patients who do not have any active disease or who are already in remission, the Mediterranean diet can help them maintain low levels of fecal calprotectin, which potentially could help keep them in remission for a longer period of time. So this could be a good diet option for maintenance of remission too. There's also some additional health benefits like improvements in quality of life, improvements in cholesterol levels, and improvements in the composition of the gut microbiome too. Like I mentioned earlier, there is one small study on this diet looking at it for prevention of pouchitis, so I wanted to highlight that there. When patients who just got their J-pouch created adhered closer to a Mediterranean diet, we found that over the course of 8 years, they had lower levels of fecal calprotectin overall, and they also had a higher % chance of having a normal pouch over the course of 8 years compared to patients whose diet looked further away or much different from a Mediterranean diet overall. I also threw this final slide in here on a plant-based diet because it kind of falls in line with a Mediterranean diet and a specific carbohydrate diet. There have been a few studies out there just looking at, in general, whole foods plant-based diets. And this study specifically looked at newly diagnosed patients with Crohn's disease who were started on infliximab and a plant-based diet at the same time. And they found that over the course of about 10 years, the line that we're going to be looking at are the pink and the black lines there. About half of patients, or 52%, did not have any relapse of their disease. And this is a big improvement because over the course of 10 years, the normal relapse rate of Crohn's disease is much higher. Only about 10 to 23% of patients go 10 years without having a flare-up. So this study found that 52% of patients on both the infliximab and plant-based diet did not have a flare-up over that time. So a significant improvement adding on this plant-based diet in this study. Finally, we're going to talk a little bit about a low FODMAP diet. So this is a 3-phase diet that was designed to identify fermentable carbohydrates that may cause or exacerbate people's GI symptoms. And it was originally studied in a different disease called irritable bowel syndrome. We really only have research in this diet for adults at this time. Both people with Crohn's disease or ulcerative colitis can benefit from this diet. But as you can see, the severity is all redded out there because we really do not want to see any active inflammatory bowel disease. We want somebody's disease to already be in remission if they're going to start a low FODMAP diet, because it really is mostly beneficial for improvement of symptoms. It has not been shown to be very helpful for improvement in any of those biochemical markers of inflammation or endoscopic markers of inflammation as well. It's also important to note that somebody with a history of eating disorder or disordered eating probably should not be starting this diet or should be working very, very closely with their care team or a registered dietitian. And so why is having a diet like this important? Over the course of about 6 years, about 2/3 of people with IBD will experience IBS-type symptoms. And so those are GI symptoms where we're not really seeing any active inflammation, but people are still getting, cramping, diarrhea, abdominal pain, bloating. And so having a diet option that can specifically target these symptoms, even if you are in remission on colonoscopy, or if your inflammatory levels are on the lower side, can be really beneficial for up to 2/3 of our patients. And so this is a nice study that looked at this low FODMAP diet for people with inactive IBD who are having these persistent GI symptoms. And they found that the low FODMAP diet was much more effective than a sham diet at providing adequate relief of these GI symptoms. So you can see the low FODMAP diet in that darker blue color there. About half of patients, or about half of the patients on that diet had adequate relief of symptoms compared to the less than 20% of patients on the sham diet. There was also an improvement in quality of life for people following this low FODMAP diet too. And that study really just looked at that elimination phase for 4 weeks, but the low FODMAP diet is a 3-phase diet, so I wanted to talk about all 3 phases. So there's that elimination phase where we remove all these high FODMAP foods for normally about 4 weeks, ideally to improve symptoms, followed by that reintroduction phase where we add these high FODMAP foods back into the diet to potentially determine what specific FODMAPs were triggering those symptoms. For people, most of the time, it's usually about 2 to 3 out of the 6 FODMAPs that are triggers, which means there is the opportunity to add back a few different food groups or a lot of foods. And that's really this concept at the very end of personalization, adding back in the foods that aren't triggering symptoms, only avoiding the foods that we need to, and that helps in the long term for maintaining this diet. And that can really help with this idea of maintenance of remission or maintenance of these symptoms with this low FODMAP diet. So to conclude, there are multiple different dietary options that have been shown to be helpful for inducing and maintaining remission for people with IBD. We want to make sure that we're choosing diets that have been shown to be effective for the type of IBD that you have, and that will help you reach your very specific remission goals. You want to partner with a registered dietitian just to make sure you have all the tools and resources needed to follow the diet safely and successfully. And really, based on this talk especially, we need more evidence and research on how diet can help people with IBD induce and maintain remission. Thank you.
Thank you so very much, David, for your very informative presentation. Just a reminder that if you do have any questions, to please direct them to the Q&A box on the bottom right. So as we continue to gather the questions from our audience, we wanted to share with you a video we recently recorded for our Gut Friendly Recipes website of a quick and easy protein smoothie courtesy of registered dietitian Rachel Dykman, who serves on the Food Foundation's Pediatric Affairs Committee. Hope you enjoy.
Hi, my name is Rachel Dykman, and I'm a registered dietitian specializing in IBD. And today we're going to make a banana and peanut butter smoothie, which is featured on Gut Friendly Recipes. So in this smoothie, we have bananas, we have milk. We're using skim milk today, although if you are lactose intolerant, you can always use a lactose-free option, or you can even use something like soy milk or any other milk alternative that you prefer. And then we're also adding some ice to make it a little bit thicker, as well as some peanut butter. And if you have a peanut allergy, you could also use something like sunflower seed butter or really any other nut or seed butter that you like. So first I'm going to start by cutting up a banana. Bananas are great because they're really rich in soluble fiber as well as potassium and some ice. well as our milk.
Just a note, the video is having some buffering issues for a lot of folks, so the video will be available on the website.
So that's how you make.
I think we're going to go ahead and move on to the Q&A portion. All right, so at this time, we'd like to resubmit the 2 questions from the beginning to see how much you've learned.
The banana and peanut butter smoothie. And for the full recipe details, you can go to
We can stop sharing.
gutfriendlyrecipes.org.
There we go. Let's be patient, everybody. There we go. So if you could take a moment and please re-answer the 2 questions from the beginning of the webinar. Just a second. Go ahead and fill in your question, your answer for question 1 and question 2. Okay, great. So this is great. So the correct answer for our first question is inducing remission. We've learned that EEN is not recommended as a dietary option to maintain remission due to the restrictive nature of being on 100% liquid formula. For our second question, the correct answer is gluten-free diet. The other diets have all been studied in comparative or controlled trials, as David explained in his talk. Thank you all for taking the time to participate in these polls. And now we can take some direct questions from our audience. I'd like to welcome Danielle Gaffin onto the camera, who has been answering questions for us throughout the chat. We appreciate you taking your time to do that. Let us now direct a few of the audience questions live, and I'm going to go ahead and start. And as a reminder, please do send your questions to the Q&A box. So for the first question, we're going to direct this question to David. A patient asked, in this presentation, you are speaking about diet and remission rates. Does this refer to diet alone or diet plus treatment, for example, a biologic?
That's a great question. A lot of the studies that we have are also using biologics at the same time. A good example of that was that plant-based diet alongside the infliximab. Some of the studies have used diet alone, but it tends to be a little bit more rare. I would say those are more often the exclusive enteral nutrition or the Crohn's disease exclusion diet studies, specifically in pediatric populations.
Okay, thank you so much. So the next question is going to be directed to Danielle. What are some vegetables and fruits you recommend slowly incorporating into your diet after a flare?
That's a really great question. And I would encourage whoever's asking it to get some personalized guidance here because your food tolerances and triggers may be really different than the next person with IBD. That being said, I would recommend starting. I think it's important to talk about the types, but also how that vegetable is reintroduced, how that produce is reintroduced in a way that's going to set you up for success to tolerate it. For example, in terms of types of veggies, you could start with ones that are more rich in soluble fiber versus insoluble fiber, which may have more bulk and roughage passing through. It may just be gentler and help to make stool a really nice texture as it's passing through as well. That being said, so like examples of those could be like certain squashes, maybe like a zucchini or a butternut squash could be a really fun side that you cook. Also though, peeling some of those veggies may remove some of like, especially if it's a thick peel, may remove a lot of that insoluble fiber or bulk. And then finally, absolutely, you could puree it or change the texture to make it super soft and just set you up for that much more success to try it out.
Okay, great. I would very much agree with you, Danielle. As a patient, I worked closely with my nutritionist as well. And what we discovered was for me that I needed to maintain high fiber. So smoothies and pureeing were my go-to. And then after that, a lot of information came and research came out about saying how that's really good for folks. So I appreciate you responding in that way. It certainly helped me. So for Danielle, another question we have is, and actually for David as well, for plant-based diets in research, is this vegan, vegetarian, pescatarian, or does it have its own parameters?
Yeah, that's a great question. The one plant-based diet that I had put in the slide deck, that was actually a lacto-ovo vegetarian diet. So it included both dairy and eggs. Fish was allowed once a week and red meat once every 2 weeks. So pretty low in animal protein overall. In general, a few of the other plant-based diets, it really just depends on the specific study, but I don't think any of them were vegan, if I remember correctly.
Yes, that's what I've seen as well in the research, David. Yeah.
Great, thank you. So how can we best find and access IBD dietitians like the presenters, especially for those of us on Medicare, Medicaid, which doesn't necessarily cover dietitians for IBD?
Yeah, I think a great starting place could be to ask your gastroenterologist if they have a referral, if they know anyone. Some offices do refer to dietitians pretty regularly, so that's usually the first step I'd recommend. Also, on the foundation's website, there is a specific web page on finding an IBD focused dietitian. So that could also be, hopefully we can put a link to that in the chat, but that could also be another way. There are a few other sources too. For example, the Academy of Nutrition and Dietetics is a great database of dietitians all around the United States, all people who are registered and credentialed to help.
Yeah, you hit all of them, Danielle. Those were all the ones I was going to mention too.
Oh.
Okay, great. So this question is directed towards David. I've heard of going dairy-free as being helpful for reducing symptoms and or inducing remission. Is there any evidence of this? Have you seen this anecdotally?
Yeah, it's a really good question. I don't think we have a ton of evidence for that at this time. And in fact, a lot of the diets that we talked about today include dairy. The Mediterranean diet includes low-fat dairy. The specific carbohydrate diet includes long fermented dairy products like yogurt. A few of those supplements we talked about too that you would use on exclusive enteral nutrition or partial enteral nutrition are dairy-based as well. So I don't think there's a lot of evidence, at least that we have at this time, showing a dairy-free diet could be helpful. Some people with inflammatory bowel disease do feel like they develop a temporary lactose intolerance. And so doing dairy that is a little bit longer fermented, like your cheeses or your yogurts, compared to your milk or your ice creams, potentially could help if some of the symptoms you would have are like bloating, abdominal pain, diarrhea. So that is something to experiment with, on a personal level.
Great, thank you. So David, you talked a lot about Crohn's, but I was wondering about the effect of some of these diets in UC and if they even do anything.
That is a great question. There is some research on a Mediterranean diet for ulcerative colitis. One of those studies looked at the Mediterranean diet for maintenance of remission in ulcerative colitis, and that's the one that actually found that we did see lower levels of fecal calprotectin there. So that was one of the studies that did show benefit. And then there are a few other ones kind of in the works currently looking at ulcerative colitis. One of them is called the ulcerative colitis exclusion diet. But again, we're still kind of getting research in that area. But recently, the American Gastroenterology Association did say that for both types of inflammatory bowel disease, a Mediterranean diet is something we can recommend due to the research that we have. So even for ulcerative colitis, there has been some studies there, enough to make that recommendation by the American Gastroenterology Association.
Great, thank you so much. Danielle, is there any evidence that a diet high in fiber is helpful for Crohn's disease?
Yes, we are getting more and more evidence that anti-inflammatory plant foods that do contain fiber really are beneficial for the gut microbiome and may help someone stay healthier for longer, may have longer periods of remission. That being said, adding fiber to one's diet really can be tricky. So I do recommend working with your healthcare team and dietitian to increase to an amount of fiber that is safe for you and well tolerated. And ideally, we want to incorporate a lot of different types of plant foods for an optimal diversity in the gut microbiome. And we want to increase those foods at a pretty gradual, slow pace, not going from 0 to 100 for fiber, since I don't think anyone would feel good doing that, but a slow and steady pace so the gut can get used to processing it again. Absolutely is something, if possible and if safe, we want to do.
Great. So this is a question for all of us. Do any of you feel comfortable sharing about your own journey from dealing with a diet related to Crohn's or UC, and Danielle in particular dealing with your family member, and David for yourself?
Sure, yeah, I can start out. I'm definitely comfortable talking about it. It's my own personal experience, so it's not going to be the experience of everybody on this call, and it's not going to be the experience of other IBD patients. But I found that my disease is very, very diet responsive. So I have a set of food triggers that I know I really need to stay away from. And then I have a real list of safe foods too. And that's really actually evolved over time. And that can be one of the most frustrating things for both me and patients is when you have a safe food and like something happens and all of a sudden, things change, you get a surgery, you're on a new medication. That's happened a few times to me. But right now, a lot of the things I eat are oatmeal, blueberries, bananas, pretty easy to digest, simple foods like that. And it does help a lot for me to consider diet. I wouldn't be an IBD dietitian if I didn't think it mattered. And I found that to be true in my personal life.
That's so powerful, David. Thank you for sharing that. My husband, Ari, who has Crohn's disease, is also an open book. So happy to share his journey. He's 6 feet and at his lowest weighed 127 pounds from symptoms of the disease. When he was first diagnosed, and this was 17 years ago at this point, his family asked his gastroenterologist, like, should we change his diet? What do we do now? And long story short, at that time, and granted, we had much less nutrition research for IBD at that point, but his doctor said, no, keep on eating what you're eating. And unfortunately, I think that kind of backfired for Ari, my husband, because he developed so much fear and anxiety around foods that he just stopped eating because he was worried that food would trigger his symptoms. So yeah, long story short, I helped him on his journey discover what his food triggers maybe were. And then by focusing more on the foods that made him feel good, we were able to slowly but surely boost his confidence around food and eating again. So long story short, we've been together about 10 years now, but today he weighs over 200 pounds. So very nourished, has a lot more energy to make it through the day, and doesn't have fear around food anymore.
That's great. Thank you for sharing that. My story is rather similar to your husband's in that when I was first diagnosed, it became very panicky and emergency-like, and I tried to figure out what I can and cannot eat. And I did lose quite a bit of weight, which was very concerning. But I was lucky enough to connect with a dietitian who only treats IBD patients. So she really helped get me set on a good path, because I was also told eat, drink, and be merry and everything should be okay. And over the years, I learned that, alcohol is not for me. It is my number one trigger. I went through a variety of eating different types of foods. I definitely started with a specific carbohydrate diet, which as a mother with children is a little really difficult to do. And then I moved into the IBD AID diet, which I found to be more helpful. So when I'm in a full flare, I will go gluten-free because that helps reduce the gas in my system, which will decrease the pain for me. So that has been, I can say anecdotally, very helpful. And currently I'm moving towards the Mediterranean diet, specifically towards working on my gut microbiome and really just improving that as best I can, adding in more, fruits and vegetables. I was dealing with a lot of disordered eating. I was afraid to eat so many different things. And now I think I had gotten down to eating maybe just 10 different items. And now I'm eating probably 20 different fruits and vegetables a week, which is fantastic for me. And that's really with opening up my mind and saying, hey, I can do this. And so, as I mentioned, fiber was really important to me, and making sure that I relied on smoothies to get myself there. And I kept telling my doctors, fiber matters, because I knew the difference. We know the difference when we're dealing with our own bodies. And so I continue to move forward with making that happen. So I think it's really important that we advocate for ourselves as patients. If they're telling us to eat something that's not working for us, to stand up and say, hey, that's not working for me, but this is what's working for me. And knowing that everybody is, everybody's body is different, and particularly where your Crohn's is, or your ulcerative colitis is in your colon. But when you have, in my case, I have Crohn's colitis. So I knew what was working for me and what wasn't. So it's going to be different for everybody. So, well, thank you for sharing your stories. I've heard of going dairy-free as being helpful for reducing symptoms and or inducing remission. Is there any evidence of this? Have you seen this anecdotally? Oh, did I ask that question already? Oh, I'm so sorry.
Yes.
Hang on, let's roll on back. Okay, I've got a good question. The chat and the questions are all together, so forgive me for that. So David, how much difference does it make in what form we consume the same food item? So example, in solid, liquid, blended versus whole, hot versus cold, cooked versus raw, and why does it make a difference, say medically?
Yeah, overall, I think a lot of patients anecdotally say that it makes a huge difference. And there's a few different reasons for something like that. Most of it comes down to how easy those fibers in those foods are to digest. So anytime that we're modifying the texture of a food by blending it, pureeing it, getting it softer, that's just going to be a little bit easier on the gut overall. And there's going to be a less of those like irritating or tougher to digest fibers that our body's going to have to break down. Same thing, cooking versus raw. You're adding heat to these fibers. You're breaking down those cell walls. You're softening them from a texture standpoint. You're making those foods a little bit easier to digest. One of my favorite things to point out is ripe versus unripe fruits actually makes a huge difference. So a banana, if it is unripe, can actually have 10 plus grams of fiber, mostly in the form of resistant starch. As that banana ripens, it actually goes down to around 2.5 or 2.6 grams as those undigestible starches turn to more digestible sugars. So small little changes like that, especially for your fiber-rich foods, can have a huge difference. Peanuts versus peanut butter, hummus versus chickpeas. And I think those are really the best ways to be introducing those foods, especially in a flare-up, just to help control some of those symptoms, and help make it a little bit easier on the gut when there is inflammation.
Thank you so much, David. So I have another question for you, David. What diet is best for those with a J pouch and Crohn's? This combination has its own unique challenges.
Yeah, that is definitely a tough one overall. There's a few different diet options available. We found that a Mediterranean diet is likely beneficial for both of those. We also have found, again, one very, very small study on the Crohn's disease exclusion diet that has shown that there could be some benefit there. So those would be the two that I would think of, straight off the bat, because both have been shown to be beneficial for both pouchitis or J pouch and Crohn's disease. Those are probably the ones that I would start with or think about.
Thank you. Danielle, the research on probiotics, I've seen can benefit UC patients, but not necessarily Crohn's disease patients. What have you seen on that?
Yes, I agree with you there. The most research we have, and granted, these are on very specific types of probiotic supplements, because not all, like when you go down the probiotic supplement aisle, you have a bunch of choices, right? And not all of them are the same. They have different probiotic strains, different doses. The ones we have the most strong research, which is only saying so much at this point, is one called Visbiome, which is known previously in the literature as VSL number 3. Long story short, there was a lawsuit, the formulation changed, so it's no longer VSL number 3 if you want that one used in the research studies. Long story short, for that very specific type of probiotic supplement, the most research we have on the effectiveness is for pouchitis. So people with a J pouch or some form of a pouch to prevent that inflammation and infection. For ulcerative colitis, the research is more mixed. That's why even for UC, it's not every single person with that condition is prescribed these probiotic supplements. So, I would recommend, because these probiotic supplements are quite expensive, um, to really have a conversation with your healthcare provider if they feel it's worthwhile to try it out, or maybe not, since the research for UC, it's mixed. It's just not one size fits all there. For Crohn's disease, we don't have research supporting that very specific probiotic supplement can benefit at all, just based on the current research. So, if there's not research to support it, why waste your money?
I would agree with you. It's very expensive, and I have myself tried the Visbiome. So one last question. How does one test the microbiome, since so many of us are now interested in understanding the connection? How would we go about doing that if we wanted to?
Yeah, that's a really good question. And normally when we talk about the gut microbiome in these studies, it is somebody's taken a sample of stool and they've put it through a bunch of lab tests and they've isolated specific strains of bacteria to really understand the composition of somebody's gut microbiome. Practically speaking, I don't think that's an option for most of us or any of us at this time. So the best way to really identify a healthy gut microbiome is to look at the output, stool consistency. If you're having healthy, normal appearing stools, that's usually an indication of a healthy gut microbiome. Also, factors like the absence of bloating or absence of symptoms, that can be an indicator, as well as, normal levels of fecal calprotectin can indicate overall a healthy gut microbiome too. So those would be some of the ways that, practically speaking, we as patients can kind of identify it. But in reality, we're really not there yet, being able to ask our GI doctors, hey, can we have a microbiome test, and kind of give me the rundown on what that looks like. At this point, the testing just isn't there yet.
Yeah. If I may add to that,
Of course.
I totally agree with you, David. I think there are still some pretty big limitations to the value of those tests. Um, One limitation that I think is really powerful for patients to be aware of is that the gut microbiome can change as we change our diet and the food we eat in a matter of days. So right now, the turnaround time for a lot of those tests you see online is a few weeks to get, those results back from the time you give your stool sample and send it off, and they analyze it and then give you the results. Like, say it's 3 weeks turnaround time, like your gut microbiome could be a lot different in that period of time. So that's just one of the laundry list of issues I have right now. But I think at this moment in time, we're not quite at a place where the value is there to really realistically see what's going on.
Yeah, I would absolutely agree with that. It's not something that we recommend at this time. I'll also point out too, and you kind of brought up a good point, in people's microbiome, we don't really know what healthy is at this point. We can say that there's, different types of or different composition of gut microbiome that are found in people all across the world that are considered healthy or beneficial, and they look very different from each other. So again, kind of talking about targets, if we don't know what we're aiming at, how are we going to have accurate tests, or how are we going to understand what the goal is? And so we just need, again, more information, better options before we consider something like that.
Great. Thank you all. This was a great discussion, and we learned so much helpful information today. So as our program comes to an end, on behalf of the Crohn's and Colitis Foundation, we encourage you to keep learning about IBD and to visit our helpful educational resources. To learn more about everything we discussed this evening, please visit the Foundation's webpage on diet and nutrition. Here you can learn about the diets discussed this evening, as well as malnutrition, supplementation, and how diet can impact your IBD. Additionally, we have a great resource for you to explore, our gut-friendly recipes website. This is a database of recipes. You can search for dietitian-approved recipes based on diet, type of meal, or specific requests like vegetarian or gluten-free. The IBD Help Center provides information and resources to patients, caregivers, and healthcare providers about IBD. They're available by phone or email, as well as live chat, currently available Monday, Tuesday, and Thursday. If you're looking to connect with other patients and caregivers, the Foundation offers virtual and in-person support groups. The QR code at the bottom right of your screen will help you locate a support group near you. Finally, to watch previous webinars and expert conversations, please visit crohnscolitisfoundation.org/myibd learning. I want to remind everyone to please fill out the evaluation survey that will be sent to you after tonight's program. We really appreciate the feedback and it will help us plan future programming. Thank you to our wonderful expert presenters and to our IBD community for joining us tonight. Have a great rest of your evening.